This is Dr. Talal Nakkar. I'm going to talk about evidence review of high-frequency oscillatory ventilation. This is part 3 of this presentation. We already talked about the basics in the first presentation and initial settings and adjustment in the second presentation. This is the 37th presentation in this series of mechanical ventilation. You can review the other presentations on this channel. So let's start talking about indications of high-frequency oscillator in adults. First indication as a maintenance mode, early application of high-frequency in ARDS patients. We used to think that it has better lung protection comparing with conventional modes, low tidal volume and high beep. This was before 2013. In 2013, this was proved to be false, and we are going to discuss that in the next few slides. As the other two indications remaining for the high frequency are the rescue therapy and as for refractory hypoxemia and refractory hypercapnia, especially for ARDS patients. We already discussed that in presentation 22. There is other option for refractory hypoxemias. Higher beep may be one of the options. The other is prone position. High frequency is an option, and other option is to use an ECMO. So as we said, before 2013, high frequency was a promising treatment for ARDS patients. This meta-analysis showed that high frequency is superior to conventional mechanical ventilation. This is 2010, and it contained these 1, 2, 3, 4, 5, 6 trials. Look at the number of patients, not that much, and most of the time it was compared with old-fashioned mechanical ventilation. This 2002 DERDAC, the most important one of these trials. They used high tidal volume in the conventional mode. So in 2013, there was two large randomized control trials published at the same time in New England Journal of Medicine. First one is the Oscillate trial. This is large randomized control trial. It's Canadian, Australian, and Saudi Arabian trial. They compare low tidal volume, high beep, conventional mechanical ventilation, which is the standard of care, with the high frequency oscillate. So their results showed that early application of high frequency oscillator, as compared with the ventilation strategy of low tidal volume and high beep, does not reduce and may increase in hospital mortality. Actually, they stopped this trial prematurely because of the increasing mortality. The preterm analysis showed increased mortality, so they stopped early. They were planning to randomize around 1,000 patients. I think they stopped at around 550 patients. So high frequency here was not equal, but inferior. It increased mortality. The other trial, which is the English trial, the Oscar trial, showed that high frequency oscillator is the same as conventional. So the use of high frequency has no significant effect on 30-day mortality in patients undergoing mechanical ventilation for ARDS. So after these two trials published, there was less enthusiasm for high frequency oscillator, and the intensivists around the world started to study why this mode failed, or why this ventilator failed to show any benefit or even harm in ARDS patients. So here we have this observational trial. They are trying to see which patient will improve on high frequency. So you initiate high frequency for some patient. So what parameter can be looked for to see if this patient will improve in the long term, or you should shift him to other mode. So they think here, if you put the patient, high frequency is effective in improving oxygenation in adults with ARDS, particularly were instituted early, because early application means early recruitability. So if the patient improves his oxygenation, change in the BF ratio during the first 3 hours of high frequency can identify those patients more likely to survive. So your patient needs high frequency, you change him to high frequency. After 3 hours, you do ABG for him, you compare it with the baseline ABG. If his BF ratio increased by around 38, improving BF ratio, that means the patient will continue to improve. If he did not improve, that means his lung is not recruitable, and you may think in other modality of rescue therapy like ECMO if it's available. So since 2013, most of the papers and reviews came to the journals, try to answer the question why high frequency failed to show mortality benefit or even more harmful in ARDS patients. In this review by Ferguson 2013, he mentioned 3 reasons. The first reason, the deleterious effects of increased sedation. In these 2 trials, the sedation was more in the high frequency arm, and the sedation well known to cause harm for ICU patient. This is one of the theory. The other more important theory is the hemodynamic embarrassment due to reduced right ventricular preload or increased right ventricular afterload. Well known that positive pressure ventilation will decrease preload, and in these 2 trials the mean airway pressure was really high. In the Oscillate trial it was around 30, the mean airway pressure. In the Oscar trial it was around 26. It was 31 in the Oscillate and 26 in the Oscar trial. The other also important factor, the right ventricular afterload. Also positive pressure ventilation will increase the right ventricular afterload, and this is important factor. The other third important theory, an increase in mechanical alveolar stress and strain within the baby lung. The theory of high frequency oscillator was to reduce ventilator associated lung injury in conventional mechanical ventilation. So surprisingly, that the theory now that this machine or this mode of ventilation will increase value, not decrease it. So why it did not work? They concentrate on lungs and forget about the heart. They use very high mean airway pressure, 31 in Oscillate trial and 26 in the Oscar trial. So positive pressure ventilation will increase right heart afterload, and that will cause right heart dysfunction and failure. And positive pressure ventilation will decrease right heart preload, and it can exaggerate hypovolemia. So hypovolemia means more fluid, and more fluid, it's worse outcome for any patient, including ARDS patients. So in this trial, they try to study the right ventricular function during high frequency oscillatory ventilation in ARDS patient. They have randomized patient to conventional mechanical ventilation, then they change them to high frequency plus 5 of mean airway pressure. So you take the mean airway pressure in the conventional, you increase it by 5, then you increase it by 10, then you increase it by 15, and they study the right ventricular function by echocardiography during all of these manipulation. So they discover, or they confirm, that right ventricular dysfunction, this is dysfunction, and this is right ventricular failure, is common in ARDS patient, and it increases when we apply higher mean airway pressure. So this is conventional, this is plus 5, this is plus 10. You see increasing in the prevalence of right ventricular dysfunction and right ventricular failure, and this is plus 15. So here in CMV it was, the mean airway pressure was around 18. Here with the plus 15 it will be around 33. If you apply mean airway pressure of 33, so right ventricular dysfunction is really high, and the right ventricular failure by their definition is around 50%. So they convince, or they confirm, that using high frequency, using high mean airway pressure under high frequency oscillator ventilation can worsen right ventricular function and may cause right ventricular failure. So instead of saying do not break my heart, I would like to say do not break my right heart.
Break my right heart.
So if you want to see a good result, you have to protect lungs and heart at the same time. In this study, they tried to find how prevalence and the prevalence and the prognosis of cor pulmonale during protective ventilation for ARDS patients. So they found that it's around 22%. From around 150 patients they studied, 22% they were having they were having cor pulmonale. These patients were on conventional mechanical ventilation with protective lung strategy, means low tidal volume and high beep. And when they try to find the reason why this patient is having right heart failure, so they found the higher driving pressure and infectious cause pneumonia as a reason for this patient to have right heart failure. When they compare the mortality, you see this patient is having ARDS without cor pulmonale, and this patient is having ARDS with cor pulmonale. So apparently the mortality is higher during with cor pulmonale, and it's significant statistically. Again, this is without pulmonary circulatory system dysfunction, so mortality is around 30%. This is 28 days mortality. It increased with moderate right heart failure to around 40%. with a severe right heart failure dysfunction, it will increase up to 60% the mortality. In hospital mortality as well, it will increase, and this is significant statistically. So when they try to find why this patient is having right heart failure, they try to find ventilator settings with these two groups. This patient does not have core pulmonary, it's 177 patients, and this patient is having core pulmonary around 49 patients. So tidal volume, it's the same in the both groups, 6.6, 6.2 is not that different. Respiratory rate, it's not that different. Beep is not that different, is 9.8. Plateau pressure, we think that plateau pressure should be higher with the patient with core pulmonary. It's 25, 23 without core pulmonary, but it's not significant. So the thing that is significant, the driving pressure. Here in the no core pulmonary, it was 14 and it was 17 in the core pulmonary. So driving pressure was more important than plateau pressure in developing core pulmonary in these patients. So instead of talking about lung protective strategies, I would like to talk about right ventricular protective approach. What's good for the right ventricle is good for lungs. In this review, they try to find what settings on ventilator might protect right ventricle more than other settings. So keeping plateau pressure less than 28 centimeters of water, doing lung recruitment, controlling hypercapnia, PaCO2 less than 55 to 60 millimeters of mercury, and improve lung mechanics and pulmonary circulation. How to achieve these goals? By decreasing tidal volume, that will limit overdistension, by adjusting beep according to the right ventricular overload. This is one of the way of adjusting the optimal beep, to do an echo after each adjustment and see what's the best for the right ventricle, and this is one of the approaches for optimal beep, and there is study about that. Maybe removing HME, decreasing the resistance in the circuit, controlling hypercapnia, and increase respiratory rate without generating intrinsic beep. The intrinsic beep is as bad as high beep. This is uncontrolled beep, auto beep. And maybe considering bronch positioning, that will decrease the stress on the lung, increase the recruitment, and might also decrease the afterload of the right ventricle. So third theory, why high frequency oscillator did not improve mortality or increase mortality? Does it relate to the ventilator associated lung injury? In this issue of Intensive Care Medicine 2015 December, these two reviews, it's very nice review, I recommend you to read it. Does high pressure, high frequency oscillation shake the foundations of lung protection? Did studies on high frequency oscillator ventilation fail to improve ERDS survival because they did not decrease VLI? So high frequency, this is maybe from the one of the papers. So high frequency oscillator ventilation is supposed to prevent or reduce VLI by avoiding positive alveolar opening and closure at lactate trauma, and also positive inflammatory cytokines released due to alveolar instability by a trauma. As a matter of fact, it's difficult to imagine a better means to stabilize alveoli than high frequency oscillator. So it's supposed to decrease by high frequency, not to increase. And that's why what can explain the difference between theory and practice. We think something by theory that will decrease. There is a lot of suggestion, but on the real life it might be different. So the first review by John Marini, I just quoted these statements. Occult VLI could have developed during oscillate for dynamic reasons that relate only indirectly to static stretch mechanism. The other point, that global tidal volume during high frequency may range from 100, we think it's very low, less than dead space, but it might reach 400 ml, which is really high, varying inversely with cycling frequency. If you use a frequency of 3 or 4, and that's if you have refractory hypercapnia, so tidal volume might be as high as 400. And this is really not lung protective, especially you are using very high frequency. The other paper, they try to find why maybe they just summarize the argument why high frequency failed to improve mortality and decrease VLI. There is experimental arguments, clinical arguments, and other arguments. I'll just try to read it quickly. So for the experimental arguments, high frequency was tested on animal models. So in these animal models, ERDS was induced by saline lavage. It's different than the real life ERDS. We have patients with pneumonia, with infection. So lung will be more recruitable for these animal models. It's more recruitable. So whatever is applied for these animal models may not necessarily be applicable for ERDS patients for real life. It's very different from adult ERDS, which is heterogeneous and less recruitable. The recruitability is different, and the heterogeneity is different. The other thing, that end inspiratory overdistension caused by high tidal volume or high B both induce VLI, and this is really important because we used to think that high tidal volume alone is responsible for ventilator-associated lung injury. Now, because this is what we call dynamic strain, the high tidal volume is dynamic strain. But what about high beep or high mean airway pressure, like in high frequency? So this is what we call static strain, and this really might induce lung injury as well as dynamic strain. Also, the other thing, that oscillation amplitude and frequency potentially raise cell and lung parenchymal stress. Energy delivered to the lung may be quite high because of the deformation amplitude and high frequency. Resonant frequency may promote delivery of higher pressure and volume. They assume that resonant frequency for lungs and airway is around 8. If you use 8, you will have really high tidal volume, and this is physics. What about clinical arguments? As we mentioned, the high mean airway pressure in the two recent trials, so in the OSCE around 31, in the OSCAR 26, this may have caused lung overdistension as attested by high incidence of barotrauma in this higher mean airway pressure, and right ventricular failure as suggested by hemodynamic compromise with higher mean airway pressure. Other thing, the difficulties inherent to the technique, lack of effective alarm. So if you have life-threatening condition like tension pneumothorax and tube obstruction, you don't know really if there is a problem. So you have to do something else like X-ray, you do VBG. So no possibility of patient transport while on high frequency. So all of this theory might have all caused this an improvement in mortality or maybe harm with this machine. In this review, they try to collect that data between the mean airway pressure in these patients and the barotrauma. So whenever you have higher mean airway pressure, there is good correlation between barotrauma and mean airway pressure, and this is expected. So the higher pressure, the higher barotrauma. So what about the mortality? Also, they found that there is really good correlation between mean airway pressure and mortality. So the higher mean airway pressure, the higher mortality. So how to make the high frequency more safe? So use lower mean airway pressure. In this review in 2014, I think Ferguson was part of it. Even he tried to study why, or he tried to find out why high frequency oscillate might increase mortality or did not improve mortality at least. So the issue of the frequency, delivering smallest tidal volume possible, this is the target. But if you did not achieve higher frequencies, their target was more than 6, so that might deliver higher tidal volume than anticipated, and that might cause less lung protection or maybe harm. And the other issue, the possibility of the resonance phenomena. So what about the beep, the mean airway pressure? So open atlected lung and sit in the safe zone, that's the target. But what about the failure of these? So lack of lung recruitment, if the lung is not recruitable, especially if the late ERDs, that will cause overdistension. So hemodynamic compromise, decreasing venous return, right ventricular dysfunction, myocardial depression, vasodilation, and positive fluid balance, and this is really bad. The other thing, that the heavy sedation and paralysis, you have to use it during high frequency. All together might be an explanation why this machine failed to cause mortality benefits. So, no early use of high frequency oscillation in ERDS patients. What about refractory hypoxemia and hypercapnia? You have patient in conventional mode. He failed his refractory hypoxemia. He's setting less than 90 with FiO2 100 with high beep. It might be an option to shift him to high frequency, and this is one of the options. Any study about that? Right now there is no study to support or to refuse. If you have other modalities, so which is better, using high frequency or using ECMO? Really, there is no study to compare. But what's proven that prone position, it's decreased mortality. So one of the things that might do it, if you did not do it already, is to prone your patient, and this is by evidence. And we might discuss it in the next few presentations, discussing the prone position in ERDS patients. In this meta-analysis, they try to find the effect of high frequency versus conventional mechanical ventilation. I just have this table, which is talking about refractory hypoxemia. When they just compare the refractory hypoxemia in these small size of patient, like in Ferguson in 2013, the oscillate, they just found 273 patients, or 275 and 273 in the conventional. So this is half of the patient they used to have refractory hypoxemia. And the other trial as well in Poland and Derdak and this trial. So in refractory hypoxemia, it favor high frequency oscillation. Is it an evidence? It's not a real evidence, but this is one of the options, as we said. What about high frequency during hypercarbic or hypercapnic failure of conventional mechanical ventilation with ERDS patient? Also, it's an option, and this just observational trial, they found it's feasible and it really works. So just look at the BF ratio in this patient before high frequency. It was not low, it was accepted. I will not say not low, but accepted, 150, and it did not affect by shifting the patient to high frequency. On the other side, look at the acidosis, 7.2 and around 70, the BaCO2 67. So by shifting to high frequency, it improved the pH and improving the CO2. So one of the options for refractory hypercapnia, if you did not tolerate, the patient is not tolerating permissive hypercapnia, did not tolerate high rate, did not tolerate deep sedation. I will not say deep sedation, because the patient should be already on the sedation and paralysis when you have shift him to high frequency. Did not tolerate the bicarb, so maybe one of the options to shift him to high frequency oscillator. Also, other option to use extracorporeal CO2 removal or ECMO as well. And there is no comparative study up to my knowledge. So it was feasible, and it works very well in these kind of patients. So take home message: when applying high frequency oscillation, clinician should consider monitoring lung recruitment by oxygenation response or other means available, like let's say we say BF ratio. So you measure BF ratio after 6 hours of shifting your patient to high frequency. If it did improve, that means good sign. It did not improve, you have to think about other modalities. The other thing to monitor during high frequency, the right ventricular function, maybe by doing echocardiography. If the right ventricle is not doing well, your patient will not do well. That might ensure that this unique mode of ventilation is achieving appropriate physiological goals in the individual patient. This will be the end of discussion of high frequency oscillator. We discussed it over 3 presentations. I hope you enjoy it. I would like to remind you to subscribe to this channel, and thank you very much.